So thank you first to Murray and to Margaret for having me here again. And thank you to Murray for putting me in the enviable position of being what is standing between you and lunch. So I will try to move this along. As Murray mentioned, he asked me to end our panel on an optimistic note about what may be a path forward. And this is kind of akin to what I talked about last year, where I'll try to take perhaps more of a bipartisan view and focusing on coming back to my roots as an economist. And last note is that any views that I express here are my own professional opinions, not that of my employer. So starting off, coming back to basics as we try to look for a path forward. What is going on in the current healthcare market? So what is a market? And if, for those of you who were here last year, heard a bit about this. A market is where, when a market is working perfectly, where you can have suppliers who are able to enter and exit pretty seamlessly, where you have interoperability and interchange of the goods that are being sold, so that there isn't stickiness where somebody likes one particular product and so is hesitant to move to another equal product. Along with that, where you have complete transparency, where people who are the consumers who are purchasing know exactly what the benefits and costs are of the different options to be able to make that purchase. And they also know exactly how it affects them, and they're the ones driving the decision making. That's healthcare, right? So, healthcare clearly is an imperfect market, as all of you laughed. And I think this is something that provides a common starting point. Competition. We all know about concentration in the healthcare markets on the insurance side, on the provider side, and there are a lot of costs associated with entering and exiting the market that gets to that whole issue of you don't have people easily entering or exiting. Public goods. There are goods in the healthcare market that people can benefit from without having to buy it. A perfect example is herd immunity for vaccines. So people can rely on others to make decisions that would then benefit them. Externalities. There are benefits to a transaction that are not necessarily included in the decision making in that particular transaction. So a good example for this is workplace productivity as the result of a healthcare decision. They're kind of seen in two different economic spheres, but certainly decisions that are made in the healthcare sector can impact workplace productivity. Another example is prevention, something that a payer may not see an effect right away if someone is undergoing preventive services, which is going to avoid something down the road. And so that's not necessarily included in that particular transaction. Information asymmetries. Patients don't always know what the benefits and costs are for the options for their treatment. Their provider knows more than they do about the situation of their health condition, what the different options are, so there is that information asymmetry. And also, there really isn't good transparency in cost and quality of providers, which again makes it difficult for a consumer to be a true consumer. And then finally, market distortions. So in a healthcare market where we have a third-party payer who is footing most of the bill, you don't have that sense of really understanding the cost of what you are purchasing as that patient or as that consumer. And on the flip side, the way that providers are reimbursed, the traditional fee-for-service model, as you all know, can lead to some incentives in terms of what is actually reimbursed or what is valued in terms of the care that's provided, which comes down to different codings, and also the fact that making a phone call to talk to a patient is not reimbursed, but having the patient come in to have the exact same conversation is, and so that leads to some distortions. So this is kind of the overview of some of the ways that the healthcare delivery market is imperfect. And it lays the foundation for what I think people on both sides of the aisle know are things that need to be addressed. So what this means for delivery system reform, that we have to address some of these market failures. And this comes back to how MACRA, the Medicare Access and Chip Reauthorization Act, is bipartisan. A lot of the thoughts around improving the way the market works is bipartisan. And one of the other keys here is that uncertainty is very harmful. So as you are trying to encourage more investment in quality or improving the way that care is being provided, a lot of these are upfront investments that can take time to show effects, and that if you're not also changing the way that the interactions are occurring between the patient, the payer, and the provider, then everything can fall apart. So the uncertainty is harmful, and so continuing to kind of move forward is essential. So coming to MACRA, and I'm sure a lot of you are familiar with MACRA, which was bipartisan legislation. I'll just give a brief overview. It repealed the SGR and instituted a new way for payments, the Quality Payment Program for Medicare Part B payments. So the first is the Merit-Based Incentive Payment System, or MIPS. Where providers report on a few categories: quality measures, advancing care information, health IT, clinical improvement activities, resource use measures, or cost. And then a score is developed, and payments for Part B are adjusted based on performance, with a plus or minus 4% variation in 2019, going up to plus or minus 9%. The other track for the quality payment program is advanced alternative payment models. And so this is looking towards other ways of creating payments with providers, such as accountable care organizations, bundled payments, and I'll talk through some of that. Here, if physicians receive a significant share of their revenues through an advanced alternative payment model, they will get a 5% payment incentive for the next few years, and they're not subject to MIPS. And the criteria for these advanced alternative payment models is that providers must bear more than nominal risk, meaning that if there's an arrangement where there is a set threshold for how much money will be spent on a procedure or on a population, if the provider goes over that, they share in the cost. If they go below that, they share in the savings. So a two-way risk, or they're part of a medical home model. The quality measures should be comparable to those used in MIPS, and participants should use certified EHR technology. And again, I'm assuming that the lingo is familiar to all of you. If I need to back up and explain any of these more, I'm happy to. So from this legislation, HHS had to take a look and see, of the existing alternative payment models that are out there, which ones qualify for MACRA because of those criteria that I laid out for you. So here are the existing alternative payment models when MACRA was passed that qualified for an alternative payment model. So comprehensive joint replacement model, which is a bundled payment. So there is a target price for the joint replacement through 90 days post-discharge, attached to quality measures. Again, if the providers, surpass that, they cost less than what that bundle was, they get the savings. If they go beyond it, they eat the cost. And again, it's adjusted based on the quality, their quality measures. Comprehensive ESRD care, that is around kidney care. It's an accountable care organization, oftentimes with dialysis facilities. Oncology care model is a bundled payment for oncologic services. ACO tracks 2 and 3, so the accountable care organization model, where you have groups of providers that are held accountable for the cost and quality of the care they provide to their patients. Tracks 2 and 3 are the tracks where there's that bidirectional financial sharing of risk. Track 1 is where if they beat their cost threshold, they share in the savings, but if they go over it, they don't share in the additional cost. So that one did not qualify. Comprehensive primary care plus model. This is a model where providers pair with payers in their area, where there is a management fee, primary care management fee, for being able to do things like telephone calls instead of having the patient come in, doing web visits, et cetera, enabling providers to be a bit more flexible outside of the traditional fee-for-service realm in how they're providing care. And then there are payment incentives associated with the outcomes measures provided. So with these models, I looked in terms of how many providers are currently in them. It was about 700 providers in these models. For the comprehensive primary care plus model, about 3,000 practices. So certainly there's a lot of room for growth, and I think that with MACRA, and again, coming back to all of the market inefficiencies that we talked about at the beginning, the goal really was to move towards more of these, alternative payment models. So some new alternative payment models that were developed, they were developed in the Obama administration, put out in December and January, right before the administration ended, but have continued. Track 1 plus ACO, so providing another option for providers who don't want to necessarily take all of the downside risk. They share in 50% of the savings and only 30% of the losses. So giving another option for providers to bring more providers in. BPCI Advanced, so this is bundled payments with 29 inpatient and 3 outpatient episodes that basically provides a target price for a bundle of care and quality measures. So it's similar to the other bundled payments and qualifies as an alternative APM. So again, to think about how we move forward to address some of the issues discussed. MACRA also developed a physician technical advisory committee, again, with the idea that we should continue to look at ways that we can innovate. This technical advisory committee has 11 members, physicians, non-physicians, experts in health policy and in particular in delivery system reform, to evaluate new payment models, make recommendations to HHS, and to date, they've reviewed 21 proposals. I've listed here the criteria for those proposals. You can just read through value over volume, integration of care, patient choice, patient safety, etc. And I think the key point here is that there are recommendations that PTAC has made for new models to be put in place. So one is Hospital at Home Plus. This would be a model that would provide a bundled payment for more acute care services to be provided at home, along with a 30-day transition after the acute phase of services is done. And there's also an option for this model for palliative care. So this was one model where the PTAC said, there is a huge space right now in Medicare where as more and more care is moving out of the hospital and where we want to meet patients where they are for us to be able to provide care in the home setting, and also to improve that transition of care then, because it's the same provider who's doing that more acute type service and then transitioning for the next 30 days after that acute care service. So that was recommended for full-scale implementation. Another example, American College of Surgeons and Brandeis put forward an advanced alternative payment model for bundled payments in surgeries. So they had more than 50 episodes of care, including appendectomies and other such procedures, where you'd have a bundled payment from the procedure to 90 days after discharge. And the PTAC recommended this for limited scale implementation. So let's start with a smaller number of procedures because, again, these problems that have existed in the healthcare market have existed for a while. There is no silver bullet. So how do we start to move in a way that we can see what the effects are of different types of arrangements to evaluate, make adjustments, and then move forward? So the PTAC recommended this for limited scale implementation. So these are just some examples to the points that were made before about moving forward in the Medicare space. This also has ramifications and reverberations outside of the government, because a lot of times private payers are working alongside and looking at what Medicare does, and even working in partnership through the Healthcare Payment Learning and Action Network and through the Healthcare Transformation Task Force. So there is a lot of movement in this regard already that this would kind of continue. And I think the last thing, again, as we think about what are next steps in policy and what can government do, there were some lessons learned that the PTAC put forward that provide some opportunities for some next steps. One thing they noted, you have all these providers who are now coming forward and bringing forward, okay, the healthcare market isn't working right now. Here are some options and here are some things that we would like to try. But as the PTAC noted, physicians, it's not surprising that physicians are not very good at designing payment models because their expertise is in delivering care, not in designing payment models. And so one of the things they noted is it would be helpful for HHS to provide technical assistance to submitters in payment model design. So to provide workshops explaining the key building blocks of payment models, talking about when adjustments could be made to current payment models versus developing new ones. And also, in particular, one criterion had been an area of stickiness with a lot of submissions around health IT, and I'll come back to that. Having more access to data and to analyses. One of the things that MACRA did was it did open some of the Medicare data to be able to combine with other sources of data, because again, how are we going to best determine how to improve the care we're providing to our patients without having data where we can track people and we can look at outcomes and we can look at costs? And the PTAC also encouraged increased access to data, and taking a simple example that you could have you could have a population that's pretty small, or you could have a rural organization where they don't have the budget, they don't have the consultants who can go and who have access to the Medicare claims data, who can churn to be able to predict what the effects of different models would be. Well, there needs to be an opportunity for leveling of that playing field a bit, to be able to give the smaller organizations some assistance, to be able to do the data analytics needed to determine how they can improve. HIT, so one of the criteria for these new models is how can we leverage health information technology to better inform care? One of the big barriers to that, interoperability. And so where is there an opportunity to continue pushing on interoperability so that we actually can then leverage the sharing of information across different care settings, so that we can move more towards this population health-based model and breaking down the silos that exist in care? Having a ready path for limited scale testing. So again, there's no silver bullet. If there were, I wouldn't be standing here today. So how is there an opportunity for more limited scale testing of some ideas where you can then collect the data, evaluate, make adjustments, and then move from there? And the recommendation was for HHS to basically develop a path for that to be possible, especially given some of the recommendations like the one I mentioned with the American College of Surgeons. And finally, they noticed that there are many barriers to innovation in the current payment systems. So sometimes what actually needs to happen is not a whole new payment model, but rather a restructuring of codes in the existing fee-for-service model. So that there are opportunities as well within the current payment structure to address some of the issues that providers and patients are bringing forward and payers are bringing forward as barriers to having this market work in a more efficient and effective way. And so this just gives a sense of where things can go moving forward. PTAC is completely bipartisan, MACRA is bipartisan. A lot of what I mentioned in the beginning is basic health economics 101 that you learn when you do your first health economics class. And so really there are opportunities, again, returning to basics, where we can move forward, given everything that was said by other people on the panel. Thank you.